Hey folks, Scott Weinger here, and this is an EMCrit podcast. Today on the podcast, we're going to do the first in what is a series on critical illness in the liver patient. And today we're going to concentrate on acute liver failure. Before we get into that, a quick mention. It's been so long since I've mentioned this. I don't know why I've forgotten about it, but I wrote a book. I edited a book with a buddy that is spectacular. It's called the Resus Crisis Manual, and it was designed just like the checklists that pilots use, where you could just open up a page and just see what is known as the boldface, the things you immediately need to do to stabilize a critical illness. And then on the next page, it has all of the additional information you may need. This format is unique. It's fantastic. I loved editing this book. The authors we had were just spectacular. And I think you'd really love it. But you don't have to guess. You could actually check out some sample pages of it by going to resuscrisismanual.com. That's resuscrisismanual.com. If you don't own a copy, take a look. I think you'll like it. If you like EMCrit, if you like Fulminant, you will like this book, I think. I'd be really surprised if you didn't. So take a look, and that's all I'll say about that. So let's get to acute liver failure. Now, what do I mean by acute? Acute liver failure is in contrast to a few other conditions. So there's cirrhosis, the long-term chronic liver patient with acute decompensation. That's when they have a failure of something related to the liver, but they have no extrahepatic organ failure. And then there's acute on chronic liver failure, where they have chronic liver failure, as the name implies, but now they have an acute decompensation. And this is signified by not just liver failure, but extrahepatic organ failure. And we'll do a show on that one specifically because those patients are super sick. And then, of course, there's the critical care of the cirrhotic with a non-liver illness. And then there's liver dysfunction secondary to critical illness. So they have no intrinsic liver problem. The liver has gotten hit by their critical illness. So we'll do all of those others in another episode. Today, we're just going to deal with acute liver failure. And acute liver failure is further subdivided into its acuity. So if your time from jaundice to failure to hepatic encephalopathy, which is the real signifier of failure, is less than 7 days, that's considered hyperacute. If jaundice to encephalopathy is 8 to 28 days, that's acute. Though that doesn't seem very acute, right? And then 29 days to 12 weeks is subacute. So that's the further subdivision. And then really what we're going to be talking about today is the fulminant acute liver failure patient, which means like they're super sick. And this is the patients you see, their transaminitis is in the thousands. They are already floridly obtunded. They're really, really sick patients. And that's primarily what we're going to be dealing with today. Now, this is not an area of true expertise. I have level 1 expertise on this, as does every practitioner of critical care, but I am not an expert. So I sought out an expert. And there's no better expert than Tasneem Pirani. She is the lead at King's. You know, King's is like the liver center. It's where the King's criteria comes from. She's the clinical lead for all things liver critical care. She's brilliant. She's super cool. I've been trying to get her on for a year, and she had a baby in the mix, and babies take precedence over EMCrit episodes. So we had to put it off, and I was so happy to finally get her on the line because she is a font of information on all things liver critical care. And if you like this, let her know in the comments, and maybe we'll get her back. All right, let's roll right in. Tasneem Pirani on the critical care of the acute liver patient. Oh, I should also say, the way she came across my radar is she wrote a fantastic review paper on the critical care of the liver patient for the general intensivist. It was published in the anesthesia literature, so you probably would not see it if you're not a critical care anesthesiologist. So check that article out. It's linked in the show notes for this episode at emcrit.org/386. All right, let's jump in. Who are you and what do you do?
Of course. So I'm Tasneem Pirani. I am the clinical lead for the liver intensive care unit at King's College Hospital. And my background is that I trained as a hepatologist and an intensivist in London. And I've been a consultant at King's for the last almost 10 years now. So I'm living my dream. I'm doing both of my favorite jobs, which is critical care and hepatology. So it's great.
That's super cool. I did not know there were GI intensivists out there. I knew there were some renal intensivists. This is amazing. I love it. That's such a cool app. And for people that don't know, King's is where the King's criteria is, a place that has been obsessed with liver for many years. So you are the perfect person to talk about the topic of today, which is acute liver failure. And you were the senior author for an amazing publication on the management of these patients for intensivists. And that's actually how you came across the radar for me. So I highly recommend people reading that. And I'll put that in the show notes so everyone will be able to bask in the goodness of that article. Now, I guess the place to start is where I would start if I saw one of these patients in the emergency department, Tasneem. So if someone comes in jaundiced and maybe they're a little bit altered and they can't even give any history, no one's with them, how do you start working that patient up to figure out what's going on?
No, look, really good question. And it's probably the most difficult part of the entire assessment of this patient. And it was why we decided to write this article, because it's where things go horribly wrong. Everybody looks at a jaundice patient. There is an assumption that this must be cirrhosis, etc. The idea is that if a patient comes to your emergency department with jaundice, your whole premise is trying to decide whether this is a primary liver pathology, so a primary liver injury, or a secondary liver injury. And I'm just going to explain that a little bit more. So a primary liver injury, what we mean by that is that the injury has occurred to the liver itself, and any other systemic or extrahepatic manifestations is as a result of the liver being unhappy. And again, that can be further split into, is this an acute liver failure? Which we mean is the patient had a completely normal liver, no history of chronic liver disease, and then had some sort of injury to the liver, viral injury, toxic injury, other injury, and has now presented with liver failure? Or is this an exacerbation of an underlying either previously diagnosed liver disease, or it's the first time they're presenting to your emergency department with cirrhosis and complications of that? So that's your primary liver pathology. And then you're thinking, could this be a secondary liver pathology? And that's often in the context of sepsis, or shall we say cardiogenic or respiratory failure, where the problem is not it's not primarily with the liver, it is another organ. So generalized sepsis with septic shock or cardiogenic shock, and a low blood pressure, a hypoxic injury to the liver, a generalized sort of inflammatory response has caused an injury to the liver. And so that's where you're starting. So of course, the first thing you're going to do is take a set of blood tests and have a look at those and try and interpret the liver enzymes.
All right. Now, that was fantastic, though it does leave me in that same confusion. But I know, I have faith that you're going to bring us out of this and we're going to have some ability to discriminate. So now, when you look at the panoply of labs that guidelines like EASL put out there for a patient coming in with a suspected acute liver failure, there are like 30 labs on that panel. What should we actually be sending as our initial salvo in the emergency department with a sick patient in front of us? And then we might hear what additional ones we need later.
Of course. So look, the additional ones really shouldn't be done right at the beginning, because you could send all of the blood tests and really not know how to interpret them. So the first things that would be helpful in the emergency department in a jaundice patient is your full blood count, your USANEs, renal profile, your liver profile, a coag profile, and a blood gas. And the reason I say blood gas is because you also get a blood glucose on there. So if that's your basic first panel that you get for your patients. And look, I don't say ammonia here either, because I don't think as an initial panel that's particularly useful. When you're looking at your blood panels, I'm just going to go through them individually.
Sure.
So you're looking at your full blood count. And on the full blood count, you will be able to see your hemoglobin. And if that's very low and the patient's very jaundiced, there's no reason not to think that this might be a hemolysis, a hematological problem. So you're looking at the hemoglobin, you're looking at your platelet count, and that's very useful. So that's useful both in acute liver failure, where you won't have them plummet to the very, very low levels, but you'll see that they might be low. But certainly if they are very low, you might think, does this patient have hypersplenism? Is this a chronic liver disease process, a portal hypertension process? An MCV is very useful in this situation, particularly if there isn't an obvious history, but there might be a history of long-term alcohol misuse. So an MCV is useful. You're then looking at the renal profile. And a high proportion of acute liver failure patients will have renal dysfunction at presentation. So it gives you some idea as to how sick the patient is. A very high urea and a low hemoglobin might tell you, okay, there might be a bleed in this scenario. And then you're really looking at your liver profile, so your liver enzymes. Now, we often call them liver function tests, but that's a misnomer because they're not all telling us about the liver function. You've got the transaminitis, which is telling you more about the hepatocellular damage. You've then got your alkaline phosphatase and gamma GT, which is telling you more about the biliary pathway, so an obstructive biliary disease, gallstones, congestive liver disease, that sort of thing. And your bilirubin, which again could be everything. It can be a hemolysis, so it could be pre-liver problem, it could be an intra-liver problem or a post-hepatic problem. So you're trying to look at your liver enzyme profile and saying, what's the predominant problem here? Is it a hepatocellular problem or is it a biliary problem? And then, of course, you're looking at your coagulation and seeing how deranged that is. I don't know what you use, but we tend to use the INR as our liver synthetic function marker. And then the blood gas will give you a lactate and a glucose. And all of that put together will give you some indication as to whether you're going down, this is a brand new liver problem, or this patient may have a chronic liver disease. Or, like you said, you could still be confused at this point, in which case it's not really a problem because you can start resuscitating your problem and then start adding the other investigations like the ultrasound.
All right, just to summarize that. So you're going to be sending a CBC, a chemistry, LFTs, coags, lactate, and a blood gas. But for me, if they're already sick and I'm suspecting liver, maybe they're jaundiced or maybe I have something by their history, then I'm going to be also right up front just sending an ammonia, a fibrinogen, a lipase, and a serum tox screen. And then based on those, then we'll see what other, of the countless tests we could actually send once we determine this is a liver issue for the etiology. Fantastic. All right. Now, the liver enzymes come back and they have a whopping transaminitis. And the patient, just by gestalt, is sick. They have vital sign abnormalities. They're tachycardic. They're hypotensive. So you're dealing with a serious issue here. Is it necessary, and you've alluded to this, but I really want to zone in on it, is it necessary to discern whether this is an acute, potentially fulminant acute presentation, or is this an exacerbation of cirrhosis? And since we don't have history on this patient, we don't know if they've ever presented to any other medical service. Is there anything that discernment would help us do differently now, or can we pretty much treat these patients the same at this stage?
So look, you could say you could treat everybody the same. The only difference comes on where you are located. So if you're located in a remote hospital where it's going to take you a long time to get to a tertiary center and get the attention for this patient that they may need it, this is acute liver failure because you're then thinking that this patient may go down to requiring liver transplantation and being worked up for it, then it's worth bearing in mind that you might want to do some of the investigations quickly or simultaneously while you're resuscitating the patient. So I think pragmatically, you're going to resuscitate the patient. It doesn't really matter. You may have some scaffolding in your mind where you might say, actually, this is an elderly person who we know from paraphernalia. They look like they may have ischemic heart disease. They may have diabetes because we can see that they've been checking their blood glucose, etc. So it may feel like this patient may have chronic liver disease. Whereas if it's a very young patient, you're talking about a teenager, a patient in their 20s, you might think, actually, this is more likely to be an acute liver failure patient. But you're going to start resuscitating the same way. What you do want to establish fairly early on is the degree of hepatic encephalopathy. Because as you know, if this is chronic liver disease, these patients' brains have been exposed to ammonia and toxins over a long period of time and are less likely to develop life-threatening cerebral edema early. And so you can get away with watching them drowsy and trying to resuscitate and get more help quickly. Whereas if it's a young patient in whom this is likely to be acute liver failure and their neurology is altered, then you want to intervene there very quickly because of the risk of acute cerebral edema, which could deem them unresuscitatable going forward.
Okay, you've now hit on one of the key points I wanted to get into. which is the difference in hepatic encephalopathy. But if you're okay with that, I'll put a pin in that because I want to go back just a bit to the workup of these patients initially. So what you're dealing with is clearly an ICU player. There's no doubt about that in your mind. And since you have no history, and let's say the patient is relatively young, what workup would you do on this now second round? You're seeing transaminitis well into the 5,000, 6,000, something really bad has happened here. What further workup in terms of laboratory and examinations would you do at this stage to try to discern the cause of this patient's suspected acute liver failure?
Of course. So I was always taught at medical school that if you see a patient who has a transaminitis that's in the thousands, there's only a handful of causes for this. It's going to be a viral hepatitis. It's going to be a toxin mediated or drug mediated. So toxins being things like ecstasy or very commonly in the US, in the UK, in the sort of Western world, it's paracetamol. You were in Asia, in India, then you're thinking of alternative medical therapies. And then the other thing that you want to think about is whether this is a hypoxic hepatitis. So actually the problem here is the heart. So obstructive, so big PE, obstructive shock, right heart failure, or just simply biventricular failure for whatever reason and compromising oxygen delivery to the liver. So those are your top differentials. And when you're in the ED, the first thing you're going to send off is a tox screen. So you just send up your paracetamol levels, and that's the first thing you can do. And of course, everybody now, or a lot of people now, are trained to do a quick point of care ultrasound and look at the liver, look at the heart. And you really want to look at the heart and see whether the heart's behaving appropriately. While you're there, if it's a very young patient, we've had a number of cases of MDMA, ecstasy, poisoning, if you like. So it's not really an overdose, but it's just been a bad batch, or heat shock. So we've had a number of young soldiers who've been training in the heat, and they've presented with really gross rhabdomyolysis.
Hey folks, we're just going to stop for a second because this is a free episode. I'm giving it to you in its entirety, but it's very rare that we have these full free episodes because EMCrit is a members-only site that still has foam. But if you're enjoying this content, please consider becoming an EMCrit team member. It's inexpensive. You get CME. You could write it off on your taxes, but forget all that. What it's going to do is make you the best possible resuscitation and critical care doctor you could be. You'll have the most cutting-edge, up-to-date information, and you will get it in the comfort of your car or on the subway or while running, and you'll never have to think, am I current enough or not? Am I taking the best care of my critically ill patients? All right, let's get back to the show.
Associated DIC and multisystemic disorder and liver failure. So you can add to your blood tests things like a CK to really understand that, are we talking about big muscle breakdown here as well?
And if you had a very young patient, let's say they were 16, would you be screening for things like Wilson's disease, or do you just leave that for later on?
No, of course you would. Of course you'd be thinking about Wilson's disease. So the thing with Wilson's disease, it's quite complicated. It's an inherited condition, and the patient technically has had this their whole life. They can present very much in fulminant liver failure. So in a very young patient, metabolic or inherited conditions and Wilson's disease has to be high up on your differentials. You're not going to get a turnaround on those investigations very quickly. You can send them off in the ED, but this patient will go to the ICU. You're then going to be looking for things like Kaiser-Fleischer rings. You're going to be looking for urinary copper, ceruloplasmin, and things like that. So they're not point of care, easily turnaround type investigations. But typically in Wilson's disease, so if you have a very young patient, if they have a big AST and a very big bilirubin, but a relatively normal ALP, so relatively normal alkaline phosphatase, then certainly thinking about Wilson's disease is appropriate. And often when you ultrasound their liver, they may appear to have a fatty appearance to that, but that's actually the kind of metabolic disease pathology that they have.
Fantastic. All right, let's go where we were talking about a second ago. I think this is one of the key points, is that the hepatic encephalopathy of an acute liver failure patient is very different than the hepatic encephalopathy we're so used to in a longstanding cirrhotic patient. And you've already brought out one of the key differences, which is that these patients might actually have markedly elevated ICP. How do we go about assessing and managing that specifically in an acute liver failure patient? How is that different from what we're used to?
So look, I look at the ICP issue with acute liver failure very similar to ICP if they were traumatic brain injury or intracranial hemorrhage, that sort of thing. So when they present to you, so the first thing to say is that if you are able to get a history, they will describe a very sudden deterioration. It will be a patient who is absolutely fine 1 minute and a very sudden deterioration. And sometimes, certainly in the UK, you'll have the ambulance team will say, actually, this patient was found collapsed at home, having returned from holiday. And then you find out, actually, there's been a paracetamol overdose, etc. So sometimes they present really with a low GCS. So you're looking at them with a low GCS, and then you're assessing them very much like you would any other patient with suspected raised intracranial pressure. You're looking at their pupils, you're looking at their papilledema. Often their deep tendon reflexes are exaggerated. An ammonia level that you send off at that point, and remember with ammonia, you've got to send it on ice because ammonia is released from your red cells as it goes to the laboratory. So you want to send it off quickly to the laboratory to check what the ammonia level is. And there's a clear correlation between ammonia in acute liver failure and the grade of hepatic encephalopathy. Now, unlike cirrhosis, where you have the West Haven criteria, where you grade them as grade 1, 2, 3, 4, when you have an acute presentation of a patient with acute liver failure, you're really grading them as a GCS. And if they've got a reduced GCS, you know they're jaundiced, you're worried about acute liver failure, intubate them, ventilate them, and commence some neuroprotective strategies immediately. You do the same thing that you would do with somebody who presents to you with what you would think as a traumatic brain injury or intracranial bleed or whatever else.
Yeah, this is so different from what people are used to, and unless they've actually specifically read that, they're going to treat them as if they were cirrhotics. A neuroprotective intubation for any degree of significant GCS effects from this, but they still have the potential for increased intracranial pressure. At King's, are you getting intracranial monitors on these patients? Are you using ocular ultrasound to look at their optic nerve sheath to try to assess ICP? What are you doing to actually know when osmotic therapies are actually relevant in these patients?
Yeah. So look, this is, if you were to go through a number of controversies around management of acute liver failure or a number of challenges around management of acute liver failure, neuromonitoring is very high up there. So up until recently, and certainly in the UK, King's was a big user of bolts. So we used to use subdural bolts, and we would do direct invasive measurements of intracranial pressure in a select group of patients. So select being from the evidence we know that if you're young, your ammonia levels are very high, certainly above 200 micromoles per liter. You are in renal failure. You have a very vasodilated type, so a really big SIRS response. These are all high risks for raised intracranial pressure. So we were using bolts. But more and more data is coming out to show that actually the use of bolts has reduced significantly. And actually the incidence of intracranial hypertension and mortality associated with it has reduced over time. Although we're using less bolts, we seem to be doing a better job. Partly it's because of this kind of what we call a neuroprotective bundle that we now adopt. Everybody that we think, remember, even if your patient is cirrhotic and you commenced a neuroprotective bundle, nobody's going to take you to jail for that. They'll just say that was a bit of an overcall, but fine, you protected their brain. So it's easier to do more for the patient than doing less for them. So certainly in tertiary centers or centers that look after patients with liver failure, we initiate this neuroprotective bundle quite early on. So patients get sedated, they get positioned appropriately. We don't use neck ties. You're trying to promote as much venous drainage from the blood from the brain as possible. You are treatment for hyperammonemia, so high volume renal replacement therapy is initiated earlier. And this, if you take this entire bundle together, it's meant that we're not seeing as much patients with severe intracranial hypertension. So we're not using bolts as often, but we are using other modalities. And particularly at King's, we tend to use transcranial Dopplers, not as a one-off to tell us, yes, this patient has raised ICPs, but really to track what we're doing for these patients. And we're using TCDs in conjunction with everything else we're doing it. We're using TCTs together with your ammonia levels, together with clinical assessment, together with avoiding hypothermia patients. And the other thing that we tend to use is reverse jugular monitors. So placing a little arterial line into your internal jugular, but in the opposite direction, and measuring the saturation there, really getting some idea of your cerebral metabolism and oxygen consumption.
That sounds fantastic. What are you using to determine, especially, let's say you came down to see this patient in the emergency department, should I be giving hypertonic saline or not? Because it seems like the bundle is an empiric, but these osmotherapies really need a trigger.
Yeah, sure. So if you have a patient whose pupils are abnormal, so you've got fixed dilated pupils and you're very worried that this is raised intracranial hypertension, then osmotic therapy. So mannitol you can use. So there's evidence to show you can use mannitol as a one-off dose. You can use hypertonic saline as you would in traumatic brain injuries. So you're really using your clinical skills at that point. So if they've got clonus, fixed dilated pupils, bradycardia, hypertensive, your classic raised ICP signs, then you're going to use hypertonic saline.
Yep, absolutely.
As your bolus, whatever your institution tends to use. I think for most people, they are comfortable that if you have clinical signs of raised ICP, you're aware of those, and you're going to be doing things like osmotherapy, sedating them well. If you're concerned that they may be fitting, you might give them some benzodiazepines, for example. You're going to try and cool them and bring their normothermia and the sort of bundle that you would use for, like I say, for any other intracranial pathology before you get investigations like your CT scan and things like the reverse jugular lines and things which you're more likely to get once you're established on the ICU.
And you would not, at least in my practice pattern, be giving these acute liver failure patients medications like lactulose or polyethylene glycol as opposed to what you would do in a cirrhotic. Is that your practice as well?
100%. Firstly, there's no evidence for any benefit there. And secondly, there may be harm because lactulose can cause, these patients are often very shocked. They go into immediate ileus. You then give them lactulose and their bowel just distends further. No, you wouldn't use any of the therapies like rifaximin, non-absorbable antibiotics, etc. The only real thing you're doing is trying to promote ammonia clearance. And the only real way we know that is extracorporeal therapies.
I just want to add some emphasis here because this might be the most important point in the episode, because the way we treat hepatic encephalopathy in an acute liver failure is so radically different than in a patient with chronic liver failure. In these patients, we're never going to be giving those medicines like lactulose or PEG or rifampin. What we're going to be doing instead is assuming their altered mental status is due to high ICP if they have significant hepatic encephalopathy, because they have not had a brain that has gotten used to all of the milieu of chronic liver failure. This is all new to this poor brain. And so now if they have altered mental status, ICP is your assumption. If they're not already, strongly consider or just perform intubation, a neuroprotective intubation. Consider osmotherapy, and consider, once they've firmly established the diagnosis of hepatic encephalopathy, and therefore it will not hurt their rankings on a liver transplant list, then consulting renal to consider high flow CRRT to get that ammonia level down. Now, of course, by this point, you'll have an ammonia level. And 150 is a clear must be done, 150 or higher, but anything over 100 with hepatic encephalopathy in these patients, you probably should strongly consider starting them on CRRT once they've firmly established that they are indeed in hepatic encephalopathy. And then all of the good ICP bundle we do on any neurocritical care patient: head at bed up, neck in the midline, head not kinked, kink those IJs, avoid hyperthermia, avoid dipping your MAP such that they're going to decrease their cerebral perfusion pressure, sedation to decrease the cerebral metabolic rate. You know all this. All right, let's get back in. Now, you mentioned CT scan. What additional imaging would you want? Does this patient get both an ultrasound and a CT scan of their abdomen? And I guess if they're altered, we'd certainly do their head as well. Is a ultrasound sufficient? What additional imaging do you need right now?
Yeah. So again, it depends on your institution. I know I have colleagues who work in places where they say it's so much easier to get a CT scan than an ultrasound. I think if you had a patient in ED who had altered sensorium, you're going to be taking them for a CT of their brain, because you may assume that this is all liver failure related, raised ammonia, raised ICP, but then turns out that this is some disseminated malignancy with liver infiltration and a bleed in the brain from low platelets, right? So you're trying to rule out all of the other pathologies that this could be. And if you're going to take them for a CT scan of their brain, you can CT scan the rest of them. And the reason I say the rest of them is particularly in those patients who are older, or you may suspect that there may be another pathology like lymphoma or disseminated breast cancer. These are things that we've seen in the not so distant future. Then you want to give them a CT chest, and that's often very useful for patients who are then going to be going to a transplant center because you've ruled out any lung contraindications for transplantation. And then when you take them for a CT of your abdomen, you're really asking the radiologist to comment on the vasculature to the liver, because conditions like acute Budd-Chiari syndrome, which is an acute occlusion to your hepatic venous outflow, requires you to do the appropriate scans or triple phase CT to look at your portal venous phase, your hepatic venous phase, and your arterial phase. But if you were if you were only going to be able to get one CT scan, then a CT of your brain and an ultrasound of your liver to look for any evidence of chronic liver disease, so a cirrhotic liver, but again, to look at your liver vasculature, very important.
Okay, that's fantastic. Now, the patient has their CTs planned, but we look at their hemodynamics and they're not grand. They have a MAP in the 50s right now. They're still tachycardic. And so let's talk about the resuscitation of that. Now, let's talk fluid choices first. My tendency is in my cirrhotic critical care patients, I really like albumin, but your paper and all the other papers I've seen for acute liver failure talks about crystalloids. Tell me a little bit about that. And do you like albumin in your chronic cirrhotic patients, or are you a crystalloid player in those as well?
Okay, so I often find this a difficult one to answer. Firstly, all the data we have on albumin has always been not really looking at critically ill patients, right? So the recent New England Journal was the Attire trial, and it looked at routinely giving albumin to cirrhotic patients whenever they were admitted to hospital. And they found that you actually didn't improve anything. You didn't improve their risk of renal dysfunction, their risk of getting sepsis, etc. So again, that's not your critically ill patient. When I look at a patient like the one we're describing in ED, who's coming to you in extremis, I say treat them like you would any other critically ill patient. Use crystalloids. That's what you would use. You would use crystalloids. And a time comes where you've poured in about 4 liters of fluid, and you still need more. And if you then decide to reach out for some albumin, I don't think anybody's going to turn around and say to you, oh, that's wrong, there's no evidence for that, etc. I don't think that's the case. But certainly I wouldn't in the acute resuscitative phase necessarily wait for the albumin. Crystalloids are absolutely fine in that situation. I think there was a little bit of anxiety because I think SAFE suggested that actually in patients with raised intracranial pressures or TBI, then there was a slight signal towards harm with using albumin. So I think in general, it was felt that in acute liver failure, in the acute resuscitation phase, we wanted to try and avoid albumin. So we tend to go straight for the crystalloids. And your patient who you can't take to CT, can't do anything for, completely bin those investigations. Resuscitating them takes priority. You need to try and gain some form of cerebral perfusion pressure, so getting a blood pressure up. So you're starting to resuscitate them with crystalloid, but you'll find very quickly that actually while you're pouring in the fluid, you're definitely reaching out for your central line and you're definitely starting vasopressors. And we will start with noradrenaline as our pressor of choice. If you think that this patient is suffering from cardiogenic shock, again, what you're reaching out for is for some sort of inotrope. And whether that's low dose adrenaline, then that's absolutely fine. So you're trying to almost simultaneously target all aspects of their pathophysiology.
That's fantastic. Now, I, again, in my chronic cirrhotics, might shoot for a lower MAP, knowing that their baseline is going to be a vasodilated state. So I might have a MAP of 60. But in an acute liver failure patient, I might almost argue, since we don't have actual ICP numbers, we might actually want to shoot for a higher than normal MAP. Are you pushing the MAP a little bit with the assumption? We're talking about a very sick patient here with suspected ICP. Are you pushing the MAP higher than the standard 65 we have with your vasopressors, or are you still using 65?
Yes. Absolutely. So certainly in the acute phase where you don't have any way of tracking the degree of cerebral edema, you're making an assumption that they have an ICP of 20. So you're trying to get a cerebral perfusion pressure of at least 50. So I am targeting MAPs of 70. I'm trying very hard to keep a higher MAP in these patients in the initial phase before you can get them plugged onto renal replacement therapy and start getting the ammonia lowered, etc. If you, however, have a patient who isn't in that degree of extremis, so they've come to you, they may be slightly vague, they haven't got, sort of grade 3 and 4 encephalopathy, they haven't got a really bad neurology, of course you can start off with your MAPs of 60, 65. But if you've got somebody that you've intubated, you haven't got a story on, you're worried about raised intracranial pressures, you're pushing your MAPs up.
All right. Now, you've mentioned norepi as the first choice, and that makes a lot of sense in these acute liver failure patients. I've liked vaso in my chronic liver failure patients, knowing that they have chronic vasopressin deficiency. At what point would you add in vasopressin for these patients? Would it be just like a normal septic patient, or is there...
Hey, folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
There's some predilection to liver failure-induced hypotension that would make you say, maybe grab the vasopressin earlier than you might otherwise?
So the only time that I probably would go for vasopressin first would be in hepatorenal syndrome. So if you've got a patient who is on a ward and develops renal dysfunction, you've corrected all the kind of pre-renal causes, and you think, actually, this is all related to renal hypoperfusion, activation of your renal and angiotensin system, then I might go immediately for terlipressin in this context. And the other context would be in variceal bleeds. In variceal bleeds, all the data suggests that resuscitate them with fluid, blood, give them antibiotics, and give them some terlipressin. So those would be the only two times that I'd go first for vasopressin. Otherwise, there's absolutely no reason. And I think, look, a lot of the data out there really started off with patients on a liver ward, not on an ICU, not being looked after by somebody who's experienced in using noradrenaline, etc. So that's the reason why they could use bolus doses of vasopressin, etc. So I think even in my cirrhotic patients, if they come to me with a decompensation, either due to sepsis or any other cause, I'll reach out for noradrenaline first.
All right, that makes sense. Now, you mentioned putting a central line in. People are fearful due to the extreme elevations in INR. So let me just give you a platform to tell people that INR does not preclude the performance of these procedures and does not necessarily represent that these patients are at an increased risk of bleeding. So tell me your thoughts on that.
Yeah, absolutely. So this lot of information has come out recently to describe rebalanced homeostasis. So everybody would look at an INR and would panic and say, actually, this patient is going to bleed profusely. But actually, when you use viscoelastic testing, so RO10 or TEG, depending on what you have locally, you find that often they will have pretty normal looking coagulation. And that's because in the context of liver injury, you assume that everything related to clotting, whether that's procoagulants or anticoagulants, are going to be reduced at the same time. It's not going to be that the liver is going to decide that I'm going to reduce my procoagulants more than I'm going to reduce my anticoagulants. Now, there are certain scenarios in which patients do have a slightly higher tendency to bleeding. So patients who are thrombocytopenic, they may be at higher risk of bleeding. Patients who are very hypofibrinogenic, so they've got a very low fibrinogen, so they have a higher risk of bleeding. And patients who are septic or in renal failure, they may have a higher risk of bleeding. So we often, in the context of an acute liver failure, that this was a plumb normal liver to begin with, they've now presented with a raised INR. You're desperate to get a line in. If you are experienced with using an ultrasound, we will say, please do not correct the clotting because that will affect prognostic markers, and crack on and do your lines under ultrasound guidance. If you have a cirrhotic patient who looks septic, is in renal failure, etc., and you have the ability to run a TEG or a ROTEM, then that's useful. And often if their platelet counts are very low, or if they've got a very low fibrinogen, so less than 1, then you might consider giving them some fibrinogen replacement or platelets to help you with your line insertion or any other invasive therapies. But if you're going to do an ascitic tap, so just a routine tap to look for SBP in a cirrhotic patient, you're using a small green needle, then you don't really need to correct your clot.
All right. Let's talk about N-acetylcysteine. Obviously, in a patient suspected of acute liver failure, you're going to administer it. Is there any new liver failure presenting to the ED, maybe you don't know which one it is, that you wouldn't just empirically give NAC? And what is your cutoff for saying that in a patient who is less sick than the one we're...
No, I personally, and I might be cursing myself here and I'm going to get into trouble soon, I think NAC is pretty safe. So if you are suspecting an acute liver failure and you just haven't got any history, you don't know if this is a staggered overdose, for example. You don't know if this is genuinely a paracetamol overdose. And even in non-paracetamol causes of acute liver failure, there is evidence to show that if you give them NAC early, particularly when they've got low-grade hepatic encephalopathy, there's a mortality benefit. It's thought that NAC has other putative benefits. It's antioxidant. It causes vasodilation, so maybe it improves your sort of perfusion, etc. So there is very rarely a situation in acute liver failure where I would say, don't give NAC.
All right. And even if you strongly suspected but couldn't prove that it was an ischemic hepatitis as the cause of their acute liver failure, it's probably still just safe just to give it because you don't want to miss the potential benefits for patients.
Exactly.
Fantastic. What about empiric antibiotics? These patients all have SIRS, obviously. They're super sick. Do you give empiric antibiotics for your acute liver failure patients?
Yes, look, there is no evidence for it. There's no data to show that improves or provides improves mortality, provides any benefit. But I think what you're describing is the challenge of assessing these patients. So again, if you've got a young, fit and healthy patient, they shouldn't be harboring any multi-drug resistant organisms. So sepsis shouldn't be an issue. But often you'll find that in about 12 to 24 hours, they suddenly get more SIRS-y. They become more vasodilated. And you just have no idea what the reason for this is. This further perpetuation of hepatocellular death? Is there now a superadded infection? So we tend to say that if your patient is showing signs of clinical deterioration, because remember, you can't rely on procalcitonin or CRP or any of these proteins to give you any guidance regarding sepsis, then starting some empirical antibiotics at that stage is appropriate. If you have somebody who looks like they may have visited healthcare institutions in the recent past, and maybe somebody who looks older or maybe looks comorbid and certainly has stigmata of chronic liver disease, you have to assume that they've been exposed to antibiotics in the recent past or had infections in the past, in which case you might want to start antibiotics sooner. But in an acute liver failure patient, I think you don't want to miss the window of intervening with antibiotics because we know that your degree of hepatic encephalopathy and deterioration correlates with being septic. So if you find that they're deteriorating, starting some empirical antibiotics while doing some blood cultures, urine cultures, chest x-rays would not be inappropriate.
That's fantastic. For the last topic, love to talk about a little bit of extracorporeal therapy. With the first one being one we've already alluded to, which is high-dose CRRT for the hepatic encephalopathy. At how quickly would that, let's say you had a patient whose GCS was not perfect, but they weren't at the point of intubation yet. Could you stave off intubation by aggressive CRRT?
I would say no. So starting CRRT, so I'm going to probably be describing something slightly nuanced. So do stop me if you think this is a little bit complicated. So remember, when you have an acute liver failure patient, you have to assume that this patient is suitable for liver transplantation, because in an acute liver failure setting, transplantation remains the modality of treatment and good treatment with really good outcomes. And when you look at the criteria for transplantation, and certainly I'd say the King's College criteria seems to be the universally used criteria. There are many other criteria used all over the world, but we certainly use King's College criteria. For majority of the pathologies, having hepatic encephalopathy as your diagnosis makes it as part of the criteria. So if you intervene too early and don't allow the patient to demonstrate their encephalopathy, you might be doing them a disservice here, because they then never really meet the appropriate criteria for you to then list them for transplantation. And you might find that later down the line, everything else is going wrong. Their INR isn't getting better. They haven't really got a good capacity for hepatic regeneration, but you haven't really met high-grade hepatic encephalopathy as your criteria. So what you don't want to do is start renal replacement therapy so early that you haven't actually demonstrated hepatic encephalopathy. But I think once you have demonstrated hepatic encephalopathy, and certainly if your ammonia is peaking over 100 and definitely over 150, I think more and more people now would start renal replacement therapy earlier to prevent really high-grade hepatic encephalopathy. You want to try and prevent your ammonia to rising above 200, etc., when you know that 55% of those patients will have intracranial hypertension. So there's that kind of fine line. If you're in that desperate situation, I always say this, that doing the best you can for your patient without thinking about the bad consequences that I'm doing the wrong thing and I will mess up the criteria, etc. If you have somebody, your ammonia levels are high, they're starting to get more and more encephalopathic, then often the tertiary centers will say, start renal replacement therapy and intubate them early so that you can start cerebral protection.
That's brilliant. All right. Now, I trained at a center where we had Mars. We were doing it for our patients. I didn't see any vast benefit from it. And it seems plasma exchange has transcended these more boutique systems. What is the current thinking of this at King's, where basically I imagine you have access to everything? So what's the extracorporeal liver treatment routes these days?
Sure. So, you know what? I've only ever seen our one Mars machine in the store. We never used, certainly my time there, and I was there as a senior resident, we don't use Mars. We haven't seen any benefit with Mars. And if you look at the current evidence, and it comes from the US Acute Liver Failure Study Group, where they showed that actually 21-day mortality benefit using Mars, but predominantly in patients whose cause for acute liver failure was paracetamol or acetaminophen poisoning, but not in other conditions. We are very much plasma exchange people. We tend to use plasma exchange in a couple of scenarios. So we'll use plasma exchange in patients who meet transplant criteria. So they've got to meet King's College transplant criteria. And either they don't have options for transplantation, so they have contraindications for transplantation. They're listed for transplantation, but they're making some sort of rapid deterioration clinically where you're worried that they may miss the boat. They may be too sick to transplant, in which case we're using it as a bridge to therapy. Certainly Mars, if you look at, I think it might have been an ICM publication where they said, again, that you can use Mars as a bridge to transplantation or in patients who got paracetamol-induced liver failure. But if you use it too late, so when they have high-grade hepatic encephalopathy or they've been a few days down the line, then there's no benefit at all.
This is the last question I'll ask you. Patients who we often find are the sickest, let's say you have a paracetamol overdose and we send them to a transplant center, we find almost always they don't get transplanted. And the thinking in the US at least is if we could get them through, they're going to regenerate. They're going to be okay. Is it the same at your center as well? And so who in these acute liver failure patients actually gets the transplant versus just sent to the transplant center, but it's just written out in your unit and makes it through?
Yeah, so look, majority of the patients get better with standard medical therapy. And this is because of people in non-transplant centers doing all the right things early, right? So identifying the patient, preempting deterioration, starting treatments early, preempting infections, because a lot of regeneration, etc., will be affected by suddenly developing sepsis. So the liver now has to start thinking about how to help in the context of sepsis rather than regeneration. So all of this preemptive therapy done early has really changed the fact that we don't need to transplant patients so much. So when we looked at our data, so we looked at King's data over a kind of 3 eras, we found that actually transplantation for paracetamol overdose had gone down over time. So we're not using it as often, but often we in the UK will be able to advise over telephone other centers, you're doing the right job, things seem to be getting better, don't worry about it. And often the patients who do come to us do need to be considered for transplant. But the whole other controversy around transplantation comes from the fact that our prognostic models really need to change now. These prognostic models were based or developed at a time where ICU management wasn't as good as it is now. We didn't have plasma exchange as part of our treatment strategies. We can't currently tell that if somebody meets King's College criteria, which patient is likely to get better. And if you look at the US data, there are 20% of patients who were listed for transplant were subsequently delisted because they got better. Our prognostic models currently are very challenging. They're not helping us determine who's going to get better without transplant. So I tend to bring the patients to my ICU because I have the benefit of sitting with a transplant hepatologist, a transplant surgeon, a bunch of transplant intensivists, and on a day-to-day basis, making the call, do we keep this patient on the list for transplant, or do we say that they're actually getting better and we can delist them? So it's not an easy answer, and I waffled a little bit for you, but basically what I'm trying to say is that it's a very nuanced decision-making in the context of the prognostic models probably not being fit for purpose in current times.
That's a perfect answer. And wow, I cannot thank you enough for the time you've devoted to this, because it's just fascinating. And I think there's no one in the world who is better suited to answer these questions. So I can't thank you enough for coming on the show.
Oh, thank you for having me. I really appreciate it, and I've enjoyed it, and I hope this is good.
It's fantastic. There you go, folks. You can find a wealth of information as well as Tasneem's paper at EMCrit.org/386. And again, as I mentioned at the top, check out the Resus Crisis Manual. It is right up your alley if you like EMCrit and all the things we talk about here. And you can find information about that at Resus, the word RESUS, Crisis Manual, all one word, resuscrisismanual.com. All right, Scott Weingart for the EMCrit podcast saying bye-bye.